Good afternoon. Thanks. I'm Sandra Wilkniss. I am with the National Governors Association. I'm a program director in the health division at the Center for Best Practices, and I want to thank the organizers for the opportunity to present today. My task was to bring a perspective on state strategies for scaling and spreading of successful models. Just quickly, a couple of things about the National Governors Association. It's our mission to serve in the interest of governors and their staff, and we do so in two ways. One is through the Office of Federal Relations, which essentially serves as a collective voice in Washington, D.C. with the administration and the Hill on behalf of governors. I sit with the Center for Best Practices side, which is the other side of NGA, which is more of a hybrid think tank consultancy that works with governors and their staff on specific policy projects. So accordingly, the comments I'm going to make today don't represent the official position of governors or the National Governors Association. I have to put that out there. But really are born of learnings from some of the really exciting work we're undertaking right now with states. Whoops, that's out of order, sorry. I'm going to go to this one. I just want to let you know we've been, over the last couple years and into 2016, working with about a fifth of the states, so 11 states in a sequence of 2 long-term technical assistance efforts with the generous partnership with Robert Wood Johnson Foundation, Atlantic Philanthropies, United Health Foundation, and also now Commonwealth Fund as well. We are in this current effort working with 9 states. So it's just those states that aren't highlighted in green. I'm sorry, this isn't the most useful slide, but those states that are not highlighted in green are the states that we've been working with. You can see it's an interesting assortment of states around the country. And we're currently working with 9 states, Alaska, Colorado, Connecticut, Michigan, Kentucky, Rhode Island, West Virginia, Wisconsin, and Wyoming. And I think I did them in alphabetical order. So anyway, we've had the good fortune of working with them and tons of lessons learned, but still a lot to learn and hopefully learn from this esteemed group as well. Let me back up since I was out of order here. Okay, so why focus on state innovations in this space? Well, I'm actually come to this work with about a 15-year career as a scientist practitioner. I'm a clinical psychologist and come from the academic world, and I'm sort of a neophyte in the policy world over the last 5 years. And I would say what I have learned is there's nothing like a good crisis to get policy work moving forward. So, and we know nationally that continuing escalation of healthcare costs is a huge issue. It is definitely acutely felt in states. For a couple of reasons. One is most states are required to balance their budgets. Most governors are in that position each year, and of course they have to think about competing priorities. They also, though we're recovered from the recession, it's lagged a little bit in states, and so they're still scrambling to catch up there. And I just wanted to put up this graph to highlight one thing really quickly, and that is this is a graph of state spending in major categories. I think you can read them there. Medicaid, education, transportation, corrections over the last decade and a half. And the thing I wanted to highlight is at the beginning of this decade, spending in Medicaid has begun to outpace K through 12 and is projected to continue to do so. So there's real pressure and concern with respect to bending the cost curve. In addition to that, of course, governors are hearing frequently from constituents about their concerns about their household budgets, about the negative effects of a fragmented delivery system, and also hearing from small and large businesses in their communities about how to address healthcare costs and quality and bring high-quality jobs to the state. So there are multiple competing forces bringing pressure on the situation. And so governors are taking to the stairs. They're not looking at the stairs, they're taking to the stairs. And they're doing so I think in really effective ways. This slide, which was from a Health Affairs article by former CEO Dan Crippen and Frederick Assassi, just highlights governors' role in the health system reform, and governors are actively pulling these levers. As conveners, they have the opportunity to set the vision for health reform in the state and bring together public, private partners to come up with a collective vision and a unified vision and start to execute on that. They're, of course, chief regulator and administrator, and represent one of the largest sources of health funding through funding for Medicaid, CHIP, state retirees, and state employee programs, among other things. Also, of course, locally, public health funds and behavioral health funds. So it's a real opportunity for governors to leverage all that and to try to drive progress forward, but also to work both horizontally and vertically to align the multitude of health reform initiatives that are ongoing in the states right now. I already showed you that one. Okay. I just wanted to highlight this again in the interest of time. I have a lot more information about what we're learning from working with states and how we're helping partnering with governors to work on developing a policy framework. But this is just how we're working with them at a glance and the four main buckets of activity that governors are engaging in. First of all, it's developing resources and conducting environmental scan. This is basically just to say who in the state are the leaders, the key decision makers, and frankly human resources that they're engaging in this work. How are they partnering with key stakeholders in the community and champions together to try to drive the work forward? And the environmental scan piece is really just what other health initiatives are occurring in the state and how can you leverage and align those initiatives to come up with effective and well-reasoned policy framework. With respect to the high needs, high cost population, a lot of this work, or many believe that this work is really starting there, that they can represent the tip of the spear if you can come up with some solutions that best serve the needs of that population and start to address the high cost of that population, that you can take those lessons learned and expand them to broader health system transformation efforts. So one thing that's really important, it's been said a million times today, is the underlying element here is that it's a data-driven strategy. Governors are taking on a data-driven strategy, which has its own challenges. We talked about them a little bit earlier and can a little bit later. But it's using data all the way from identifying target populations. Now we're talking primarily Medicaid claims data, pharmacy data, those types of high-level data to identify the target population, who are the high needs, high cost population in the state, segmenting that population, figuring out who they are, where they are. Somebody referred to geospatial hotspotting and understanding geography. That's a big component of the work that's being engaged in there. And then how they're interacting with the healthcare system. And that leads to clues for how to actually modify healthcare delivery and payment reforms in order to shift what's needed to best serve that population in the community and out of high cost settings. And finally, using the data to conduct some rapid cycle evaluation, track and monitor what's happening with programs that are developed on the ground, and to start to capture that return on investment in order to communicate that to partners and decision makers and create some sustainability. So data throughout for all of those purposes is a key element of what states are using to start to set the policy framework. Once they've identified the target population, they're working closely with providers and payers, maybe to iterate on some of that segmentation, to see who is the impactable population, who can we start to address the needs for now, and crosswalking that with practices that are out there, best practices that exist, and trying to understand where are the gaps, and how can we start to think about delivery system and payment reforms to fill those gaps and to incentivize use of those practices. Okay, let's see how much time. Oh, I'm talking a mile a minute, so I have a lot of time. Good. This is just to reiterate, I think, what's been discussed a lot. We're talking here primarily about Medicaid, and these are just highlights about common population characteristics that are often taken from this analysis of Medicaid claims data and understanding of who we're talking about. Rising to the top, of course, are people with serious mental illness, substance use disorders. I think it was mentioned just very briefly today, but part of that are folks who are immersed in opioid and heroin addiction and their use of emergency departments and inpatient settings and so on to try to address those needs, and then multiple medical conditions as well. Another thing that wasn't mentioned that frequently but that comes up in the Medicaid world is babies born to mothers with unstable substance use disorders, mental illness, and their NICU needs in addition to the needs of the mother. What we are hearing a lot in this work is about the social factors that are related to the needs of these populations, including homelessness, housing instability, transportation challenges, unemployment, social disconnectedness, someone mentioned that earlier, and the negative health consequences of that. Of course, we'd be remiss if not talking about complex trauma history, ACEs, for a lot of even adult people who meet these criteria, and health literacy challenges. And I wanted to try to, since we talked a lot about the Medicare population, just tell a story that I think kind of captures who we're talking about in the Medicaid space. Of course, there are a number of modal individuals who would meet the criteria for the high needs, high cost population. In the lower right-hand corner is a gentleman who, the representation is someone who's homeless, has serious mental illness and substance use disorder and unmet medical needs, who's totally disconnected from the system. And using the emergency department as his home base for any minor or major health needs. And the top left corner is a woman and her baby, and it's interesting because, and Frederick can probably comment more on this, we in our research visited a provider that's part of actually a Pioneer ACO, part of a large health system. We visited a community clinic and really tried to understand how they're working with the pediatric population. And the clinic is set up so they have adult services, pediatric services, and they have co-located down the hallway behavioral health and social support service providers. And the pediatrician actually told us this story about a woman who came in with her infant. An infant was examining her hands, and the woman was very upset and said to the pediatrician, my baby is gesturing to me in an aggressive way. She's flicking me off, and I don't really know what to do about it. And she was very distressed about it. And through that interaction, the pediatrician was able to walk with her and bring in the behavioral health provider. And it turns out, because they had the records, because they're also serving adults in this clinic, that they were able to identify this woman actually had mental health needs, some substance use needs, and some serious social support needs, was a single mom, unemployed, and so on, and really obviously needed some support in understanding the developmental phases of the baby and parenting practices and so on. The other really interesting comment that the pediatrician made is, years ago, before we had these co-located services, I might not have caught this, I might not have asked because I wouldn't know what to do. So it was really telling about a model that works and also hopefully captures a bit of a sense of the population we're talking about that's a little bit different in the Medicaid space. Okay, I'm going to try to go fast. So just to end, I wanted to talk about how some of this scale and spread, how states are engaging in this work and trying to move the work forward. And I would say that there are three main models for the high needs, high cost population and how states are thinking about policy frameworks. And they're listed here. It's not a perfect depiction of how these models work, but just take it as concepts. Some states are running at a regional collaborative model, a la Oregon, Colorado, and others, thinking about, as others have pointed out, how can providers organize themselves regionally, both for physical and mental health needs and substance use needs, but also the social support services, and how can a state policy framework support that work and collaborate with payers and providers. The MCO model, as more states are taking on managed care and Medicaid, thinking about what the policy framework looks like in partnership with the managed care entities and creating contracts that actually support this work, and then working then more closely with providers about, in some cases, risk-bearing models and certainly measurement models, a lot of quality measurement to begin the process. And then finally, the state model in situations where fee-for-service is still an important component, a part of the work that they're doing is a little bit more of a direct state-to-provider model. And finally, just some challenges and opportunities for this work. Data, we've talked a lot about it. Access to data, states have a challenge accessing even their own claims data to conduct these analyses. Data sharing, lots of opportunities and challenges, barriers. What we didn't talk a lot about is barriers to understanding who in the community has substance use disorder, 42 CFR, those types of, and state laws that might create barriers for effective sharing of data in services of this population. And then just on the delivery model side, effective coordination and integration of care supports and how to build those in, how to build capacity on the workforce side. And then finally, really trying to understand, as Frederick pointed out earlier, around the payment and delivery models, how to build those in a way that is meaningful and sustainable for this work. Okay, thank you.
Okay. We're going to go into small groups and talk about this. So if we have a question of clarity, because we're at break time, and I sense people want to get up and take a break. But if there's a question here of clarity that should be said for the whole group, hearing none, let's all take a break, well earned, well deserved. And then you're going to go directly from the break to your breakout room. And again, look at your badge, because your group may have changed. You may have gone from 1A to 2B like I did. What happened? I'm going backward. So the group A will be in this corner room 125, and B will be in 120, 120 on the far side of the building. We have a slight change. Arnie is brilliant and can do the presentation by phone. Will not be able to moderate a small group by phone. He's very talented, but so Sandra has graciously agreed to step in. So she'll be leading Group A, and David Myers will be leading Group B. So take a break, and then in about 10 minutes, if you could make your way over to your rooms and start the conversation around elements of the models and policy and kind of what we've just been discussing. Thank you.